breakfast already? Good morning. This morning we get the pleasure of listening to Dr. Jacqueline Conger present to us on natural birth trends. She joined us after a stellar career at the University of Arkansas, Arkansas State University and University of Arkansas Medical School. She's currently one of our third-year residents, hoping to graduate in a year and a half or so, if we let her. You can't convince her to stay. So please put the electronics away and give her your attention. Get to hear about natural birth.
All right, so I'm going to try and do this without a mic. I think I'm loud enough. I'm going to talk about natural birth trends. Before I start, this is an extremely broad topic, open to lots of different opinions, and something that I kind of became interested in a few different ways, which I'll kind of talk about as I talk about different topics. So just to begin, I have no disclosures, and there are too many good movie clips to pass up, so indulge me for a minute.
Welcome to the Birthing Center. In this birthing class, we are going to help you new mommies and daddies, and our mommies and mommies, lesbian lovers, marathon way. One question before we start. How many of you have been on natural childbirth? Good show of hands. That's so great. You're all so brave. And how many of you are planning on using toxic Western medication to drug your baby for your own selfish comfort? Anyone?
Baby Mama, in case you haven't seen it, now you gotta watch the whole thing. But this is a lot of what I think of when I think of people who are interested in natural birth, is the opinion that you get from that birthing coach. Sorry. Let's see if I can go away. So my objective is to talk about some of these trends that we see, and then go over what evidence exists to support, refute, just basically to look at the safety of some of the topics that people are usually interested in, or that some of the preferences that people normally have. For the purpose of this lecture, we're going to just assume that the people who are requesting these practices or wanting a natural birth are low risk, just because it's easier to talk about, because obviously recommendations change based on your risk. This is not by any means going to be an all-inclusive presentation, because there are just too many different things that people bring to the table. So just for the purpose of beginning, what is natural birth? There is no actual definition. So this is kind of what I surmised people to mean when they say they want a natural birth. They want labor, spontaneous labor, with minimal or preferably no medical interventions, no anesthesia, vaginal delivery. And I would say most of you probably agree with that based on what we see. Why? Why do we care? People have their own reasons. You could probably talk for an hour about different reasons that people have for this. One of the things that I encountered a lot just in reading and talking to people, a lot of people say our bodies are made for this, birth is natural. Some people just want to experience it as it is intended to be. Some people want freedom to kind of feel like they're in control of things, or at least not have someone else controlling things. Some people have had a bad experience with the medical system, and they fear harm from medical intervention, or they've heard someone else's bad experience, and so they're afraid for that reason. I guess this is kind of controversial, but less risk for mom and baby depending on the situation. There's also the peer and cultural pressure. It has become a lot trendy in some circles to have a natural birth. And I can digress a minute. Part of the reason that this was interesting to me was because with my first child, I thought I wanted to do all of this stuff. My mom had done it in the 80s. She couldn't have an epidural because of some Harrington rods in her back. She said, I'm not that tough. If I can do it, you can do it. And she wasn't pushing me to do it. I had mentioned it already. And I tried several of the things that I'm going to talk about, and I made it 3 hours before I said, give me the good drugs. And I was really happy after that. So I have a little bit of experience with this personally. So that kind of colored some of the things that I was interested in looking at. Other people have noted that they've had much faster recovery, and then we mentioned the previous unsatisfactory experience. So this is how we normally are presented with people's desires and requests. We're seeing photos to illustrate these things now. I do have a confession to make. When I was wannabe crunchy, I had my own birth plan. I thought that that's what responsible people did, and so I found one on the internet and I tailored it to what I thought I wanted. And again, it lasted 3 hours. I didn't have a C-section, and that was kind of my main thing, so I think it was a success. But this is kind of what we see, or this is how these preferences are often presented to us. And this is usually our response. At least if not to the patient, among the healthcare team, this is often what we're thinking. So part of my experience in researching this was to step back from my skepticism and to be more objective. Because it has been a while since I've been on the other side, and so I tend to feel a little bit more like this. So it was good to look at these topics objectively, just because we do get a little bit jaded and biased. So the first thing, labor induction. Most people don't want to be induced. So like I said, we're talking about low-risk women. Why would you induce a low-risk woman? At 42 weeks and beyond, neonatal morbidity increases significantly. You have a higher chance of convulsions, meconium aspiration syndrome, 5-minute Apgar less than 4, macrosomia, operative delivery, cesarean delivery, and then shoulder dystocia, which was significant and something else that kind of piqued my interest in this topic. Mortality is still low, but the odds do increase from 41 weeks and beyond, and that's every week it increases. One of the things that I read said that mortality at 37 weeks was about 0.4 per thousand, and it went up to 11.5 at 43 weeks. Now, I don't know anyone who's letting people go to 43 weeks, but, you know, if somebody is out of, you know, our standard healthcare system, that may happen. So if we are going to induce someone and we have that discussion about why it's important and we get them on board, how are we going to do it? So one of the more non-invasive, or I guess non-invasive is not the word, but seemingly more natural ways would be to smooth membranes. This is controversial, as most of these topics are. There has been a review that shows that there is a decrease in the rate of pregnancies that are progressing to 41 weeks after you sweep membranes. It doesn't by any means guarantee that it's going to put people in labor, but the risk appears to be minimal. There's not really good evidence on doing this in women who are known to be colonized with Group B strep, so they leave that to clinical decision making. But in the absence of someone who has a contraindication to a vaginal delivery or a vaginal exam in general, there doesn't seem to be any increased risk in doing this. So then the next topic or group of induction agents would be the cervical ripening agents. I have seen people protest about these. First one, misoprostol, Cytotec, we use this all the time. There is a lot of good safety data. This has been around for use in ulcers for a long time, and then in 2002 was upgraded to have indications for labor induction. And the main risk with Cytotec is just the chance of uterine tachysystole with or without fetal heart rate decelerations. Most of the risk has been observed when you use doses that are greater than 25 micrograms, and that's the dose that our group always starts with. The other is dinoprostone, which is Cervidil. This is also FDA approved for cervical ripening. Again, the risk is for uterine tachysystole, but the Cervidil can be removed, the Cytotec cannot. There is an increased likelihood of delivery within 24 hours, but there's been no decrease in the C-section rate. And then there are mechanical dilators like laminaria and Foley balloons, Cook catheters. These do show some efficacy, but there is possibly an increased risk of infection as well. They do have a decreased rate of cesarean delivery when you compare them to oxytocin alone in a patient who needed cervical ripening. Then another probably more natural choice would be nipple stimulation. I was actually kind of surprised at some of the things that they said about this when I was reading about it. They do specify that unilateral stimulation is safe, that there is a decrease in women not in labor at 72 hours, no uterine tachysystole observed, and a decrease in postpartum hemorrhage. However, they do show in a couple of these studies that there was an increase in perinatal death associated. Again, these are not good studies, they're not big studies, so it's hard to really make qualified recommendations based upon them. They don't say not to use it, and then this information is coming from ACOG. But they do say that this should be done in a monitored setting, so you shouldn't be telling your patient to start her own induction this way at home. Oxytocin. Yeah, I thought that was really strange. They did mention unilateral specifically, and then later bilateral they mentioned as having uterine tachysystole with fetal heart rate decelerations. And I thought that was strange. But again,
is it right better than left or left?
You should do a study on that.
Yeah,
Oxytocin, this seems to be the thing patients are most familiar with and what sometimes you might get the most kickback about. Again, the primary risk with all of these induction agents is with uterine tachysystole and causing fetal heart rate decelerations. And just for the student's sake, I know you're new on the rotation, uterine tachysystole is more than 5 contractions in 10 minutes. And that could be with or without associated changes in the fetal heart rate, deceleration specifically. The risk with this is that it could lead to placental abruption or uterine rupture, but they do cite that uterine rupture as a result of Pitocin is very rare. There are some other risks associated with oxytocin. If you inject a really concentrated dose intravenously, you can cause hypotension. We don't use it that way. Water intoxication is also possible, but again, in a large dose when it's used with a hypotonic solution. we're not doing that. So that kind of ameliorates those risks. Also, oxytocin has a really quick onset, 2 to 3 minutes. So in the event that you do have some adverse change in your fetal heart rate, you can stop it and get some resolution. Amniotomy, they are addressing amniotomy specifically in the context of starting an induction. It hasn't really been shown to be efficacious or safe as a primary means of induction. It doesn't say not to do it, but amniotomy alone, without the addition of oxytocin, is not as effective in actually starting an induction. And of course, there are always risks involved with that, including cord prolapse, cord compression, choreo, rupture of vasa previa that you didn't know about. Again, it's not discouraged, but there are better ways of starting an induction. This was something else that I didn't realize was even an issue, was that labor induction had been linked to autism in some studies. As with most of the autism studies, they could not prove any causal relationship between labor induction, specifically with oxytocin and autism. So there's been no recommendation to change obstetric practice based on that. So if we stop doing medically indicated inductions or augmentations, we're going to invariably increase our cesarean delivery rate. So the next big thing, IV access, eating and drinking. Often people don't want to be hooked up to an IV, they don't want fluids. So what does ACOG say? They recommend to at least have IV access by the active stage of labor. Anesthesia Task Force on Obstetric Anesthesia allows for moderate clear liquid intake. They do, in general, discourage solid food just because of the unpredictability of labor and risk of aspiration if the patient did need to receive general anesthesia for some reason. So ideally you want to have your patient fasted from solid food for 6 to 8 hours before an elective cesarean. Obviously, if it's an emergency, you've got to do what you've got to do. But they do recommend Bicitra will neutralize 88% of stomach contents. So definitely should use that before you proceed. Some of the studies did show that IV fluid hydration more than maintenance fluids. So what they were looking at was like 250 cc's an hour, or maintenance fluids plus PO intake has shown to decrease the length of labor. So electronic fetal monitoring. Patients often want the freedom to move, especially if they're trying to do this without any sort of anesthesia help. So electronic fetal monitoring, it can be quite restrictive. This was introduced in the 70s. It's been widely adopted since the early 2000s, and it's actually very interesting to me reading on this too. It's not really been shown to be that stellar. Compared to intermittent auscultation during labor, which is the only really other way to monitor a fetus, the overall cesarean delivery rate was increased. The operative vaginal delivery rate was increased. There was no reduction in perinatal mortality. There was a reduction in neonatal seizure, but this did not reduce the overall incidence or risk of cerebral palsy. The positive predictive value of non-reassuring pattern to predict cerebral palsy among singleton newborns with birth weights of 2,500 grams or more is 0.14%, meaning that out of 1,000 fetuses with non-reassuring fetal heart rate, only 1 or 2 will develop cerebral palsy. That's a direct quote. the false positive rate is no better. The incidence of cerebral palsy has maintained itself over many years during the adoption of electronic fetal monitoring. And so this leads to the conclusion that most of these insults that are causing cerebral palsy are happening prior to the intrapartum period that we're monitoring. So based on this evidence or lack of benefit, in low-risk pregnancies, it's acceptable to do intermittent auscultation. There's not a really good evidence-based method for doing this. One of the just to get heart tones every 15 minutes during the first stage of labor, preferably surrounding a contraction. That way you can tell whether the patient's having late decels, or every 5 minutes during the second stage. The nurses hate this. That's why it doesn't happen most of the time. To be honest, it's a lot of in and out. So usually for the sake of convenience, this doesn't happen. But if you have somebody who is really insistent upon it, there's no reason that this can't be done. So this, again, brings us to the positioning and freedom of movement. There was a Cochrane review in 2013 that evaluated upright positioning versus supine positioning during the first stage. All of these Cochrane reviews that I'm going to talk about today are either randomized or quasi-randomized trials. And in this specific one, they made a couple of different comparisons. They were comparing positioning, but then they looked at a group of women either with or without an epidural, and then a group that all had epidurals. So in the first comparison, they found that the first stage of labor was 1 hour and 22 minutes shorter, and the women were less likely to have cesareans, epidurals, or NICU admissions in the upright positioning group. In the second group, there were no outcome differences observed. Again, based on the heterogeneity of all of these studies, they usually kind of hedge in their recommendations. There's not really good evidence for this, but there's not any good evidence against it. So they recommend, sharing this with the patients so that they're aware of their options and letting them make their own decision about positioning, as long as there's no risk that we're worried about that would make them not low risk. So a couple of the other things that people might do, and I'm not going to spend a lot of time on this. There's Lamaze, which is a childbirth education that is really focused on coping mechanisms. It's usually people think of the breathing exercises that you do. This is just one of the kind of outside sources that people will take classes on and do to try to get through labor naturally. I think it was a lot more popular in the past maybe than it is now. The Bradley method is another one of those. This one's a lot more focused on basically convincing women that they are capable of giving birth naturally. So Doula Support. Sometimes patients bring in a doula. So I was confused a little bit on what exactly a doula actually is. So one of the websites that certifies doulas and trains them defines it as a trained professional who provides continuous physical, emotional, and informational support to a mother before, during, and shortly after childbirth to help her achieve the healthiest, most satisfying experience possible. So that is, by definition, what a doula is and is supposed to be. There is no standard certification for doula training. So there's a lot of variability on where people get their training and what that entails. Their role is to primarily be a support person. They're not supposed to be medical proxy or give any sort of medical advice. And that is listed as one of the things by this particular organization that is outside of their scope. Cochrane database review in 2012 evaluated a continuous support person during labor and did find benefit from this. Often that is someone like a doula. So ACOG does recommend that women should have someone available to them to provide support, and this has been shown to be better if it's not a family member. So this gets to anesthesia. A lot of different things to talk about here. Just to start with parenteral anesthesia. So all of these parenteral anesthetics do cross the placenta. There has been shown to be a 2 to 3-fold increase in 5-minute APGAR scores of less than 7, and a 4-fold increase in the need for naloxone in neonates. However, the overall incidence is still very low, and neonatal depression is short-lived. So back to the video, the toxic Western medication. Of course it has risk. All of these interventions have risk, but they don't appear to be sustained. They're short-lived and low incidence. We use a lot of fentanyl here. It has short half-life, less nausea, vomiting, sedation, not associated with neurobehavioral depression after delivery in the neonate. But you can sometimes see like a pseudo-sinusoidal pattern on the fetal heart tracing. I say pseudo just because it's not sustained once the medication has worn off. Stadol can elevate the blood pressure, so you should not use this in women with hypertension. Those are really the only two that we use routinely here, and fentanyl more so than Stadol. Demerol and nalbuphine have been used in the past. I don't really see a lot of Demerol used in any part of practice anymore. The metabolite from Demerol has a really long half-life and can cause neurobehavioral depression for 2 to 3 days. So that's just one of many reasons why I think people have moved away from using it. So epidurals, ACOG provides that all women should have access to an epidural if they choose. Just because of the superiority in pain control that it affords. So there's a lot of talk about, well, if I get this epidural, is it going to make things go slower? It has shown to increase the length of labor by 40 to 90 minutes with a 2-fold increase of need for oxytocin supplementation. And there is some controversy as to whether there's an increased risk of cesarean delivery. A couple of the studies that were evaluated showed that maybe the epidural did contribute to this if one was placed extremely early. And their arbitrary cutoff seemed to be 4 to 5 centimeters. Again, small sample sizes, small cesarean rates, not really good studies out there on this. And when they try to randomize this, there's a lot of crossover with women not being in the epidural group, switching, and things like that. So use your judgment, basically, is what they recommend. Epidural fever is another thing to consider. We don't really understand why this happens, and it's not really thought to be an infectious thing, but it does cause some risk just because more antibiotics are administered, and then you have the potential to have a baby undergoing sepsis workup, which is invasive, and they may receive antibiotics and longer hospital stay as a result of that. So a couple of the other different things in anesthesia, halogenated gases. So if someone's getting general anesthesia, these are uterine relaxants at high concentrations. Theoretically may lead to increased blood loss. This hasn't been shown outside of women who already had risk factors for increased blood loss. I know when we're doing stat C-sections and and the patient is going to sleep, we're trying to get the baby out before it really notices any effects of the gas. It hasn't been shown to have to cause neonatal depression until you reach that 8-minute mark. It's a little bit more time than we feel like we have. Spinal headache is another thing that people often complain of. About 36% of the time you need a blood patch for these, and then those are effective, I think they said about 65% of the time, but they're not as common. Epidural and spinal hematoma is rare. Transient paresthesias, pain in the buttocks, low back pain are all things that patients often complain about when they've had an epidural. The paresthesias are usually transient, like I said, about 3 to 7% of the time. And then the studies that have tried to evaluate for chronic low back pain after an epidural are not very good because they're retrospective, which has inherent bias. And then the small prospective studies, and then there was one randomized controlled trial, didn't really show any increased incidence of this. As far as local anesthesia for things like pudendal blocks or paracervical blocks, there's always a risk of toxicity with local anesthesia. This causes, it can cause arrhythmias. You can have hematoma formation or infection with those pudendal blocks. And fetal bradycardia has been seen more with paracervical blocks. So effect on breastfeeding. Some short-term effects have been seen just when neonatal rooting reflex is depressed, and this is in the infants that have been exposed to systemic opioids. This is transient, no long-term effects, so at 6 weeks the success of breastfeeding wasn't shown to be affected by whether mom received anesthesia or not. Mortality, about 5% or more of maternal mortality is attributed to anesthesia. Current rate is 1.7 per million live births. So still not high, but it is there. General anesthesia is far and away more likely to be the culprit. 32 per million live births versus 1.9 from regional anesthesia. Probably a big reason for this is failed intubation. It occurs 1 in 250 in pregnant women, just 10 times the general population. So prefer regional anesthesia if anesthesia is necessary, if we have the luxury to choose. Water immersion. So there are a couple different things to look at with this. There are maternal effects, which we'll start with, and then there are fetal effects. So in the first stage of labor, there has been shown to be about a 30-minute decrease in duration and less regional anesthesia use and paracervical block use in women who labor in water. No change in opioid use, lacerations, episiotomy, operative delivery, or cesarean deliveries, but no increase in infection rates either. In the second stage, fewer episiotomies and less analgesia, and some improved satisfaction. Inconsistent findings on the length of labor and lacerations, and no significant increase in postpartum hemorrhage. Some of the other studies that didn't really specify whether you're looking at first stage or second stage showed more relaxation, control, warmth, privacy, just overall mom feeling better in that environment. And one of the English studies showed less antepartum hospital transfers, assuming they're in a home setting. From personal experience, contractions hurt just as much when you're sitting in a bathtub as they do in a bed. That is my 2 cents. But we don't really have that capability here in the hospital, so this is not really something that we're going to encounter here, but if patients ask, I'll get to the recommendation in a minute. There are no real neonatal benefits, seem to be maybe some maternal benefits. In the first stage of labor, no significant difference in meconium staining, heart tracing, infection, NICU admission, or low APGARs. These aren't really very well-powered studies, and they didn't really look for respiratory distress either. A different study showed a 12% versus 0% NICU admission in the Immersion group, but they weren't able to link this specifically to immersion as the cause. In the second stage, there are several risks. There's a risk of infection. Some case reports have reported on fatal infections from Pseudomonas and Legionella in babies who were born submerged. There have been other infection reports, but these are the fatal reports. Cord avulsion actually is a risk as well and happens more commonly just as the baby's being elevated out of the water. And then there's theoretical risk of aspiration, which can lead to hyponatremia and seizures. A lot of the infection risk is associated with poor conditions, poor sanitary conditions. Tubs were not cleaned properly, or they were used using warm water or water that had been sitting for long periods of time. So a lot of safety concerns with the way that birthing tubs are prepared and cleaned. One of the supports for water birth is this diving reflex that neonates are supposed to have, where blood is shunted more to the head and to the heart, and heart rate decreases, breathing decreases, so that they don't inhale water as they're coming out. This has not been shown to be reliable in compromised neonates, and even in healthy newborns, it's uncertain at what time this reflex really begins. So whether that is reliable has not really been determined. So ACOG's opinion is that water immersion during the first stage of labor may have some benefits and doesn't have any additional risk. So in healthy, uncomplicated women at term and late term, this is acceptable. But as far as actually delivering and having your second stage submerged, there's not a lot of good data on that, and with as many potential risks exist, they do not recommend that. So pushing timing, this is something that we encounter more in our epidural population than in our patients who are laboring without an epidural. This is a Cochrane review that looks at both directed versus spontaneous pushing, and also at early, which is, soon within determining complete dilation, versus delayed pushing. And delayed pushing has different definitions based on which studies you're looking at. Usually you're looking at waiting an hour or more after complete dilation has been determined. So the spontaneous pushing versus directed pushing, and what they're talking about there is spontaneous pushing when mom feels the urge, not when we're looking at the strip and saying, okay, take your big deep breath and push now, or the Valsalva maneuver pushing. They noted a 5-minute decrease in the total pushing time, but no other differences really. No differences in outcome, and no adverse effects in the spontaneous pushing group. In delayed pushing, they did notice 20 minutes less of pushing in total. However, the second stage was increased by 54 minutes. So your second stage of labor is longer, but the time you're actually pushing seems to be shorter. There was, however, they noted a decreased umbilical cord pH was associated with this, but they didn't really specify whether that had any long-term adverse neonatal effects or NICU admission increase. Again, not really great evidence, any of this, so a lot of it they leave to clinical judgment. As far as the delayed pushing, it does seem to decrease your time of pushing, but then there are also the effects to the maternal pelvic floor that have to be considered with delaying pushing. So they kind of leave it up to judgment. Pushing position. The first study that I have on here was one that just came out. It was a small Turkish study that evaluated women either using a squatting bar or in semi-Fowler's position for pushing. I couldn't actually access the article, but I'm assuming that most of their patients did not have epidurals, just by some of the things that they described. They said that women in the squatting position had shorter durations of the second stage, less augmentation, visual analog pain scales were lower, but there were no differences in operative delivery or cesareans, lacerations, birth weight, APGARs, or NICU admission. And for their study, they said this seems to be better and this is more socially, culturally appropriate for Turkish women. So I just thought that was interesting. It's a very small study, probably not generalizable to our population, but something to consider. Cochrane Review in 2012 evaluated women without epidurals, comparing upright or lateral positioning to supine or lithotomy position. They showed a non-significant reduction in the second stage duration, decrease in episiotomy and instrumented delivery, increase in second-degree laceration and blood loss greater than 500, but a decrease in fetal heart rate abnormalities. Cochrane Review in 2013 evaluated women with epidurals, comparing the different positions. They didn't see any change in duration of the second stage, operative delivery, cesareans, lacerations, umbilical cord pH, or NICU admission. So it doesn't seem to make much difference in your epidural group. Perineal protection. So perineal massage, another really good clip from that movie on this, if you're interested later. Massage to stretch the perineal muscles from 34 weeks on showed a small decrease in lacerations requiring repair and in episiotomy in women undergoing their first vaginal delivery. Women with previous vaginal deliveries reported less pain, but there was not really any difference otherwise. It did show a decrease in third and fourth degree lacerations with massage during the second stage as compared to totally hands-off. So there may be some benefit there. Warm compresses have been shown to significantly decrease third and fourth degree lacerations, so this is a reasonable practice as well. As far as perineal support, which I know is something that we try to do, there haven't really been any consistent studies or consistent outcomes in studies on this. So 3 randomized studies showed that there was a decrease in oasis or the third and fourth degree lacerations, but then 3 non-randomized studies showed, yeah, there is an increase. So there's not really good evidence one way or another on this specifically to recommend or not recommend it. So here they again look at pushing position for perineal protection. In the lateral pushing position was associated with, again, lower incidence of episiotomy and operative delivery, but higher rates of second-degree lacerations. In women with epidurals, no clear benefit to positioning was noted. A different study with epidurals compared lateral positioning and delayed pushing and found higher rates of delivering with an intact perineum with the lateral delayed pushing. I believe that was contradictory to the last study that I just reviewed, though. So not any great evidence on any of this. Delayed pushing found no difference in rates of perineal laceration and or episiotomy. So again, this is just a discussion to have with your patient because they mentioned it in one of the previous studies, but there are risks associated with maternal pelvic floor injuries associated with delayed pushing, so that has to be considered as well.
Hey Jackie, did you also read the recent Green Journal article in November that said that delayed pushing actually is associated with increased second stage cesarean deliveries of postpartum hemorrhage?
No, I hadn't seen that one. Delayed cord clamping. So there's a brand new recommendation out from ACOG, I think just in this last month, on delayed cord clamping. They're now recommending it for both preterm and term infants for 30 to 60 seconds, unless there is a neonatal or maternal indication to go ahead and clamp immediately. This is different because previously they had noted its benefit in preterm infants but not in term infants. There is an additional blood volume of about 80 milliliters transferred after 1 minute. This increases the hemoglobin and iron stores and will either decrease or ameliorate the risk of iron deficiency anemia in the first year of life, which has been linked to some cognitive, motor, behavioral delays. So there is some potential benefit here. Increased blood volume also imparts more immunoglobulins and stem cells, which are responsible for cellular repair. It's unclear what benefit that may have, but it's thought to be beneficial. Preterm infants have been shown to have lower rates of neck and intraventricular hemorrhage, less transfusion for anemia, possible later benefits of improved motor function. And then term infants, again, have the higher hemoglobin and less iron, so less chance of anemia. And possibly some later social and fine motor benefit because of that. Previously, there was concern that this would lead to an increased risk in maternal hemorrhage or a decrease in postpartum hemoglobin for mom. Neither of those things have been proven. So they still recommend placing baby skin to skin, as much as the cord will allow. And you don't have to hold the baby at the level of the placenta or at the perineum. The baby will still get the transfusion regardless. One of the other things they look at was umbilical cord milking, which you guys may see us do this at some point, or I've seen us do it before, where you just push the blood into the baby from the cord. There are not as many studies on this as there are on delayed clamping. It has been shown to increase hemoglobin and ferritin, and one study showed that it did decrease intraventricular hemorrhage in preterm infants, but they still don't really have enough studies to recommend for or against this, basically. But there may be some benefit to it when you don't have time to delay clamping. Vaginal seeding. So this is in the event that mom has to have a C-section. This is kind of a newer trend, or at least it's new to us. They want to take a swab of mom's vaginal secretions and swab baby's nose and mouth to impart the same microbiome to the baby that they would have received vaginally. I know it sounds really gross.
I thought fecal transplants were better.
Yeah. The reason that people are wanting to do this is because there is a decreased incidence of asthma, autoimmune, and allergic disease in children who are born vaginally. And they have shown that the microbiome of babies born via cesarean versus vaginal delivery is different. So they're assuming that this has something to do with this benefit of less asthma and autoimmune disorders. There are not any studies really to support this yet. This is new. There are no studies to say that this is even safe. One of the biggest problems that I see with this is that we don't always test women who we know were having a repeat cesarean for group B strep. Because if they come in for a routine repeat and they don't have ruptured membranes, pediatrics doesn't care if they have GBS or not. So we're not testing everyone. So if you have mom who has GBS and then swabs her baby for it, she may make her baby sick and not realize that she's doing that. Also, you have the chance of transmitting HSV, gonorrhea, chlamydia. So there is not any good evidence to say that this is safe or that it even has the benefit that people are hoping that it has. There is one trial going on, but it's looking at the microbiome. It's not looking at any of the things that we're interested in. So ACOG does not recommend this. Home birth. So this was initially the thing that really got me interested in all of these topics. Just having a bad experience with seeing this attempted. So in the U.S., about 35,000 births, 0.9% occur at home. Only 75% of those are planned to be at home. Some of those happen unintentionally, or the patient just never seeks care and they just have their baby at home. Those unplanned home births are associated with high rates of perinatal and neonatal mortality. The question is whether the planned home births are as risky. This is growing in popularity, interestingly, in middle-class white women. That seems to be the demographic that is most interested and that accounts for most of these home births. Seem to be higher educated, white multiparous women are the majority of women who are having home births. There are not good randomized controlled trials evaluating the safety of home birth, because even in countries like England, where they do this routinely and it's incorporated into their healthcare system, women are not keen on being randomized to where they have their baby. So no randomized trials exist. So most trials are observational, retrospective, some of them are prospective, but there are inherent problems in doing any trials like that, because there is a lot of bias from reporting, from recall, small sample sizes. Lack of appropriate controls is a really big problem, because the only way that we can get control data is from birth certificate data, and again, you have your collection bias with that, and we don't usually stratify low risk versus high risk in our birth certificate data. Maybe some of the newer forms do, but that has made it difficult in the past to compare home birth data versus hospital birth data based on just the birth certificate data that we have. Again, all other reasons are that there's not really a standard level in the training of birth attendants outside the hospital, so you don't know what degree of training the person who is doing the home delivery has, at least in this country. And then you can't really attribute adverse effects very well. So there have been some benefits shown to home birth. A decrease in obstetric interventions, labor induction, augmentation, regional anesthesia, electronic monitoring, episiotomy, operative delivery, and cesarean delivery. They're associated with fewer lacerations, fewer severe lacerations, and less infectious morbidity. I don't know if you can see that table, but that's just kind of giving a comparison of some of the benefits that we see there. However, the risks. The risk of intrapartum and neonatal death and low-risk planned home birth as compared to planned hospital birth is higher, 1.3 versus 0.4% and 0.7 versus 0.1. the absolute risk is low, but in this country there seem to be higher risks of neonatal morbidity and mortality associated with home birth as compared to other countries. Breech intrapartum mortality is 13.5 per thousand, which is really high to me, and neonatal mortality is 9.2. There is also an increased risk of APGAR scores below 7, 4, and at 0 at 5 minutes, as well as increased risk of neonatal seizures. So before I go on to the next one, a lot of proponents for home birth will use European studies and even Canadian studies to compare. One of the big criticisms with that is that you can't generalize their population to ours. I meant to put a picture in here. The whole country of England and Great Britain entirely will cover a small area of the Midwest in the United States. So they have more access to hospitals and a more integrated healthcare system with midwives doing home deliveries. Also, they have a completely different patient population. I know we looked at a study a while ago, and their average BMI, or their normal BMI was around 60% of their population. Ours is nowhere near that. So it's really hard to take their data and apply it to our country because there are so many differences. So,
Jackie, if I could add, you've got 1% death per pregnancy up there. 9.2 per thousand is 1%. You can quote, that's your data. That's what you can tell your patient. I mean, I've got some in my practice right now that I try to talk them out of it. The best U.S. data, I think, is a Minnesota study from the 80s, which was a religious group that didn't allow deliveries, and their maternal death rate was 1% per pregnancy.
Yeah. So
I think we can say to our patients, we don't recommend this, we want you to be welcome in our practice, and this is the data. And that's what I do.
Yeah. So again, we may not have too much opportunity to have this conversation, but when we do, then these are the things we can talk about. Just quickly, ACOG does not recommend trial of labor outside of a facility that can expediently perform a cesarean delivery, just because the risk of uterine rupture is higher outside of planned hospital TOLAC, and it's unpredictable. I will let you read the ACOG statement on home birth and their opinion on it. They are gracious enough to say that women should be allowed to make their own decision, but that they don't recommend it, and that if you're going to have a midwife that is doing your home birth, should have a midwife whose licensure and education agrees with the International Confederation of Global Standards, which are quite stringent. What time is it?
The latest Tennessee standards for perinatal care now include birthing centers, which are considered less than level 1.
So take 1 minute just to go over midwives really quick, just because I think it's an area that's confusing. So we don't interact with them often, but there are different types, and I wish this slide showed better. There are certified nurse midwives, there are certified midwives, and then there are certified professional midwives. These are the only three in the United States that have any sort of licensing. Certified nurse midwives and the certified midwives, which there are none of those in Tennessee, only certified nurse midwives. The training for both of those meet the international standards that I just made reference to. And I've looked at their training recommendations, and they're very stringent. And they are accountable to, certified nurse midwives are accountable to the nursing board and usually practice underneath the physician. Certified professional midwives, there's not really a standard training for them. It can be either by apprenticeship or by a short course. And I think the apprentice that they train under only has to have attended 50 deliveries. And there are different bodies that will give them license. Tennessee will license them. They have a board that does that meets once a year. But essentially they practice without any oversight other than this board that meets in Nashville once a year. So if you have a complaint, you have to file it to this board, and then I don't know when they meet. So there's no other sort of physician oversight for them.
They're actually trying to change that.
They are.
QC is trying to find like an actual board certified regimen that they go through and that the PAs go through as well. And like nurse practitioners and stuff that they're going to be involved in laboring.
Yeah, there's a lot more oversight and requirements for certified nurse midwives. The farm is one of the famous places. It's actually here in Tennessee. I don't have time to talk about that, but it's kind of interesting. A lot of different references, and I went over, so if anybody has any questions.
Another quick question.
Sure.
Unless you found something different, point of clarification on the use of the misoprostol.
Uh-huh.
What I found was that the FDA changed their labeling, I think around 2012, saying that if it was going to be used, it should be used in a hospital with monitoring, et cetera, but it remains outside the indicated use.
I may have just looked at it wrong. What I had looked at, it was from ACOG, what I looked at, and I thought that they had said in 2002 they approved it, but I can look back at that. I'm not
And
sure.
you have to be careful presenting this to patients, because when we talk about inducing them in options for induction, we need to remind them that misoprostol is off-label use, unless you find something different.
I'll check it again and see what they said. I thought they had said that they did approve it.
It's kind of controversial because they say it's a warning on the warning box in 2012, and that warning box is related to use misoprostol for postpartum hemorrhage as well. So it's in the same spectrum of warning box.
I think too, we need to make a high-risk topic about delayed pushing, because I feel like there's a big discrepancy between what each one of us say, and that confuses the nurses as well, and every time they get the opportunity to have a 5 o'clock, we're not going to push for 2 hours,
Yeah.
they're all over it, because that's what changed. So it would be nice if we were kind of all on the same page as to what we were and weren't going to be on that one.
Thank you. I would like for you to be aware of the upcoming availability of acupuncture for pain control in labor, for inducing labor, and for causing version. There is an acupuncturist in Kingsport who will now do acupuncture to vert your child. There is one in Kingsport who will use acupuncture to induce your labor, but there are none available to come to the hospital and treat your labor pain. That was going to be my third career, learning acupuncture to come and treat pain, but I got to go to California and it costs $14,000 to take the course, so not now.
Well, my latest patient used acupuncture to go into labor. I don't know if it was recommended by the acupuncturist, but